Welcome back to Housing Liaison Onboarding Training. I am Sherry Downing. I am here with my colleague Ann Denton, who will speak to you in just a moment, but we are here to do Module 4, Housing and Harm Reduction. Ann, do you have anything to say this morning?
Well, I do. I would love to just share with people the perspective about how important harm reduction is to the success of a housing program. One of the things that people often talk about as a reason for someone to lose their tenancy is that they were using substances. That is going to happen among the people that you're serving, and harm reduction is going to be your key to success. So we encourage you to, we're bringing you a great starter kit for harm reduction. You'll see our learning objectives in a minute, but I would encourage everyone to explore and take additional training in harm reduction and motivational interviewing, if you can get it.
I agree. I love it. And I love harm reduction. It is an affirming way to work with the folks that you serve. When you complete this module, what we hope you'll be able to do is describe the philosophy and the principles behind harm reduction, explain the benefits, not only for your clients, but for your community, and identify some of the high-risk behaviors and corresponding harm reduction strategies that you might be able to employ. So we'll define, we'll look at value, we'll look at practical methods, and then we'll move from there into housing retention, using harm reduction as a housing retention strategy. That's a really effective tool for a whole lot of reasons, and we're going to talk about several of those. This, again, this practice really affirms people's humanity. It also recognizes the fact that substance use, as Ann said, is something that you're going to run into, and that the people you're serving will be, many of them struggling with. This can really help by taking the judgment out of it and by allowing people to navigate their own lives. And do you have anything to add to that?
I mean, I think just like all of the training that you've taken to date in this series of onboarding training, we're talking about respecting people, meeting people where they are, and working side by side with people to facilitate and help them grow their recovery. And harm reduction is another tool in your toolbox for that.
Thanks, Ann. So we all practice harm reduction, and we practice it every day. We don't even think about it. We don't even really think about it as harm reduction. What do we do when we go outside, or if we're going to the, on a picnic or to the beach or even to the grocery store? We protect our skin with sunscreen. Buckle up for safety. When I was a kid, seatbelts were brand new. That really ages me, I realize. But seatbelts were brand new, and there was a jingle on television: buckle up for safety, buckle up. And it became just a practice. Now, my kids do not even get, my kids are grown-ups now. My grandkids don't get into a vehicle without buckling up. You don't start the vehicle until all the seatbelts are fastened. Speed limits. When I will tell you, I live in Helena, Montana. When I moved to Montana in the late 70s, 150 years ago now, there were no speed limits, none at all. You could go as fast as you wanted to. If you rack it up, that's on you. But you could go 120 if you felt like going 120. We now have speed limits that are consistent with the rest of the country. And one of the ways the federal government did that was withhold highway money until you implemented the speed limits. Cigarette filters. When I was a kid, my grandpa smoked Camel non-filters. Everybody smoked. I don't know. I grew up in a family where you couldn't roll the windows down in the car because it would just bother mother's hair. Um, and everybody was chain smoking. So it was like this little pod filled with blue smoke. You never really you don't seem to see that as much anymore. And you just also don't see non-filtered cigarettes, but both of those are harm reduction strategy. And we have also, implemented harm reduction notices on cigarette packages that say, using this product may impair your health, which those are all harm reduction strategies. Those are things we run into every single day. What these seek to do is reduce the risk of negative outcomes and to promote well-being. Some of the other harm reduction strategies that we are familiar with and that we use every day, particularly relative to substance use, is designated drivers. When my kids were in their wild and woolly years, 2 boys, we would say, if you have a couple beers, call us. We will come get you without shaming you and without blaming you. We will just come get you because we want you to be okay. Designated drivers, are common now. Needle exchanges, we're starting to see those. I was just at a site visit and saw people lining up at a van in the parking lot next door to the agency I was visiting. And I said, what are they doing? He said, it's a needle exchange. Anybody can come, no questions asked, and get clean needles. Carrying naloxone has become increasingly important as we see fentanyl really infiltrating, every drug on the market right now, every illicit drug. So naloxone has been critical because people are dying and they're dying quickly. And do you have anything you want to add to this little piece?
I think this part is really important because sometimes harm reduction is misunderstood by people who are not in the know. And so I think it's really important to understand that the stuff we use every day, seatbelts, for example, are harm reduction strategies. And then it's a little bit easier to take that step into that we also are looking to reduce the harm of people's substance use without judgment and without attempting to force abstinence. And I think Sherry's going to get into that next.
Absolutely. So the harm reduction philosophy really accepts that for better or worse, we will see substance use as part of our world and part of our work. And the whole philosophy really looks to ameliorate or minimize the harmful effects rather than ignore or condemn. The harm reduction philosophy holds with the tenet that all people are capable of change, that recovery is possible and real, and people will change when they're ready and when circumstances allow. I can't say, and you need to blah, 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 and have it happen. It doesn't matter. Anne needs to figure it out all on her own, and that's okay. And some people are going to figure it out faster, and some are going to figure it out slower. And that's okay too. It focuses on keeping people safe and alive. It focuses on keeping people safe. Folks who are using drugs or alcohol to excess, the focus is protecting health. So I do sometimes a training that is talking about women's health. And this in one of the slides, which never fails to elicit a gasp of horror, is a very pregnant woman drinking a beer. Right? And yes, we all know that people who are pregnant should not be drinking alcohol of any sort. However, if this was a woman who was previously drinking a fifth of gin a day, and she has managed to reduce her use to a beer, that's harm reduction. And she shouldn't be shamed for that if she's made that kind of progress. But it's complicated, and it also sort of intrudes on people's "you should" kind of mentality, right? So but we want to focus on keeping people who use alive and protect their health. It recognizes that the use of substances does not forfeit somebody's right to healthcare and social services. And it honors the dignity and humanity of the people who use, and offers them respect and compassionate support without requiring abstinence as a precondition. Because we know that if we require abstinence as a precondition, you have to be, you have to have been sober for 6 months before you can have housing. You have to meet these qualifications. People will just feel unseen, unheard, shamed, and they, are likely to just walk away. So it's a philosophy and a set of practical strategies, and the whole intent is reducing consequences. And what would you add to that?
I would just say, I mean, people vote with their feet, right? And so if
Mhm.
I make it a requirement that someone be sober 6 months before they can get housing, then I'm either going to get the people who, some people will walk away at that, and other people will lie to me and say that they're willing to be sober and get sober so that they can get a key to the front door, and then hope I won't catch them. And so both of those things are what we don't want, right? We're talking about people who are homeless, who are at great risk from that homelessness. And we want to provide services and supports and housing to people. Let's get them indoors. And then we can work with them in a harm reduction way to help them reduce the harm associated with their substance use. And remember, in one of the previous modules, we said, and it's still true, substance use, alcohol use decreases as people become housed. That's a really strong research outcome for supported housing and housing first. Also, drug use declines over time. And so sometimes the perspective at the initial assessment is that this person is going to have a lot of problems with that, and that may happen. But let's remember the research. Harm reduction does work, and providing housing with harm reduction is a success strategy.
Absolutely. So these are the principles, and I like this little table. It pretty much narrows it down to the pithy center of the harm reduction practice. So it focuses on the harm that can result from behavior, not the behavior itself.
Mhm.
So back to my sort of case in point of the pregnant woman's drinking a beer. It is focused on harm. So clearly, if she's gone from a fifth of gin a day to a beer, she's at less risk, and so is her baby. It attempts to meet clients where they are. It provides a non-judgmental, and I want to underline this, I think it's maybe the heart and soul of harm reduction, non-judgmental, compassionate, consistent, positive regard. I love you, Anne. I am so proud that you're making progress. You are a human being, and I don't expect you to be perfect, but I will celebrate with you as you make progress. That is very powerful. It provides people with a sense of self-efficacy that, oh, maybe I can do this, and somebody's rooting for me, rather than I have to lie to Anne. I don't want her to know I'm still drinking, or I have to, walk away when I know I really need this help, because I can't quit drinking. I mean, I know not a young man, a 40-something-year-old man that I've known his whole life, and he is really struggling with opioid use disorder. Um, and it is horrifying to watch what he's doing to himself. And yet his mother is one of my best friends. And she just consistently says, I love you. I want you to do better. Please keep in touch. But this is somebody who's spinning completely out of control. She's always saying, I'm here. You can't move in with me.
Yeah.
And yet I would be happy to help when you're ready to start making steps, knowing that it's going to be difficult. It offers a menu of practical options that minimize risk. So you want to minimize the risk. That's, needle exchange at base. At least you may not pick up hepatitis or, HIV/AIDS. I mean, you're going to see, this is really important. We've said before in this series of trainings, the client has to drive the bus. You really need, with using the principles of harm reduction, to see the client as the expert on themselves. And they have to lead the process. You can lead the process, you can try to lead the process, but it isn't going to work. It has to come from the individual you're working with. And it defines success as any movement forward.
Yeah.
If you can take a step, maybe it's just making a visit to the local MAP provider, the medication-assisted treatment provider, to talk about how we might be able to use buprenorphine. Hopefully I said that right. I think I did. To begin, reducing the use or stopping the use of opioids. It recognizes that people right now, that you right this minute, are doing the best you can, the best you know how to do right now. And as you learn to do better, you do better. And it's all steps. But if you recognize that people are doing the best they can right this minute, that is a huge gift, because it also offers that consistent positive regard that is absolutely critical to moving forward with your life. And it acknowledges that recovery is a process and it's nonlinear. And what would you add to that?
I mean, I would say, let's not forget that alcoholism and drug addiction are deadly. They're deadly. Okay. And for the purposes of housing programs, homelessness is also deadly. Absolutely. For way too many people. And so you've got a population that's at high risk. And, I don't want to make it sound like harm reduction is a magic wand. We're going to lose some people. We're going to lose some people. You're going to lose you're going to lose people in an abstinence program as well. You're going to lose the people that program is not suited for, and you're going to lose people who relapse in that program. So you'll be dealing with on a daily basis two very big, significantly serious and potentially fatal conditions. Homelessness by itself places people at risk, and then substance use disorders can be deadly. So what we're saying is, within the context of a housing program, your best bet to help people avoid those negative consequences is to get really good at harm reduction and really good at working with people where they are and doing the kind of respectful persistence that Sherry's been talking about.
I love that language, respectful persistence. I think exquisitely respectful is another good term. Yeah. I think exquisitely respectful and respectful persistence are both really good descriptors for this kind of work. These often are people who are experiencing homelessness, people who are fighting addiction, dealing with serious mental illness. These are all folks who may not have received any respect for a long time. And that's one gift that you can give people, this gift of focusing on reducing harm, not the behavior, not judging, meeting people where they are. Those are huge gifts, and they may be gifts that are surprising for people, hard to recognize when they first begin experiencing it, and can give people permission to begin moving forward, honestly. The benefits, well, one of the benefits, and I love this, is it recognizes that abstinence only doesn't work for everybody. It just doesn't. It provides a framework for effectively engaging people in treatment and supports them as they move toward recovery. We can't just take people, out of their environment and put them in the recovery chair and expect that to work. This provides a framework that engages people and supports them as they move toward recovery. It offers strategies to protect people if substance use recurs. And what do we know about substance use disorders? We know that it's a recurring disease. We know that people will recidivate back to using again and again, and then start the process again. It offers by offering unconditional positive regard, by not judging, and by saying people sometimes fail, you're giving people permission to fall off the wagon and crawl back on, right? Whereas if people just see themselves as, I've failed again, I always fail, I always will fail, that acts as a real barrier to starting the recovery process again. And
Yeah, I think you've got it. I think, what we know about substance use disorders is that many times they are relapsing, recurring diseases, right? And we have all seen or known of people who use abstinence only approaches like Alcoholics Anonymous or Narcotics Anonymous, but they use that in a harm reduction kind of way. So they'll come in, stay sober for a while, go back out, come in, stay sober for a while, go back out. And every single day that they're not using reduces the harm. So that's all, it's all okay. It's all good. But yeah, I think, again, this is so important.
So I don't think we can overemphasize the implications of trauma in people's lives. I think a lot of the folks that we serve who are experiencing homelessness, along with all these other things that we're talking about, many, if not most of them, are coming from backgrounds of significant trauma, often that trails clear back to childhood. We know that homelessness in and of itself is traumatic. We know that substance use disorders are traumatic. Nobody is, I think of the man that I know who, my friend's son, who sinks a little bit more deeply into his addiction every day, and his whole life is consumed with feeding that addiction. He's lost most of his teeth. He's lost his health, I think, is dismal. He is not functioning at any kind of a level. And that in and of itself is trauma. And it's trauma compounded on trauma, compounded on trauma. And in families where substance use disorders or other dysfunction is an issue, It's easy for kids to see themselves as unloved and unlovable, as unworthy or inadequate. And what that does, it creates a pervasive sense of internal shame that then is repeated and repeated throughout, throughout the decades of life. Trauma leads to feelings of powerlessness and owning that I'm doing this today, I'll do it tomorrow, I'll do it the day after that, I fail, I'll always fail. You begin to own that. And with that comes a very pervasive, painful sense of shame. And that deep sense of shame is linked to higher forms of, higher rates of substance use, which often starts as self-medication, especially, when people may be working in a high risk, dangerous field like mining or logging or farming or any of the sort of rural jobs that can lead to injuries that can be medicated with opioids. And then when the opioids run out, it can become a self-perpetuating. There's all kinds of reasons, but what we know is that the shame, when we say, and you shouldn't have been drinking again, you promised that you wouldn't, you are supposed to be going to AA 4 times a week, and here you are with, a bottle of Jim Beam in your hands. That is not going to be helpful to anybody, especially not Anne, and it's not going to feel good to you either as a provider.
Right.
The use of alcohol and drugs or other addictive behaviors, and there's food can turn into an addiction. There are lots of ways to self-medicate and to use a variety of substances to hurt yourself. It creates further feelings of shame, and it starts this downhill spiral, right? So once that can be broken, that downhill spiral, by this non-judgmental, compassionate care that you provide. It reduces resistance if you say from the get-go, I hope you succeed. I hope this is the first day of 50 years of sobriety. I hope and wish that for you, but you need to be aware that, relapse is part of this horrible disease. And if you relapse, you have the opportunity to start all over again with a fresh new day that will be the beginning of 50 years of sobriety. This cycle of shame and addiction is common across this syndrome. So it might start with an emotional trigger. That could be any one of a number of things. Loss of a job, an angry teenager, you're a horrible mother. It can be, a traumatic memory that throws you back to a traumatic event in your life. It can be, there's lots of emotional triggers, can lead to craving, can lead to the ritual or activity, and there's some temporary relief. Oh, yeah, I can just feel those, those constrictive threads around my heart loosening up with that drink or whatever. And then the second that I sort of get away from that, from use, and suddenly I'm sober again, and then the regret and guilt and shame start all over. That cycle is debilitating, and it can turn into a fight for your life, quite literally. Anything else, Sam, about that?
No, I think that though this is good context for understanding, kind of where people are coming from, and that sometimes people are not going to be able to believe in the possibility of recovery for themselves. And so that is a direct result of this downward spiral. In a couple more slides, you're going to see there's an upward spiral. So I want to leave this slide on that note.
I like this. I like the way this is conceptualized because I think it really does capture what we see people trying to survive. And when you feel at your core that you're a failure, that you're not good, that you know, if I would just not pick up that bottle, I would be doing way better. But I pick up the bottle, so I'm horrible, you know, kind of cycle. That's not a helpful path out of the issue.
Right.
I spoiled the surprise. I love this quote. It's by Nora Volkow, who used to be the NIDA director. And she just says, I met a man who was injecting heroin in his leg at a shooting gallery, which is, as we all know, a makeshift injection site. And his leg was severely infected. And I urged him to visit an emergency room, but he refused. He said, I've been there. I was treated horribly on previous occasions. And so I'll just keep, I'm paraphrasing here, I'll just keep doing what I'm doing. I don't want to be humiliated again. This is not an uncommon scenario. We've probably at this point, if you've been doing this work for any length of time at all, have seen this. We've also, seen the person who continues to smoke despite their COPD and emphysema, despite the fact that they can barely get, air into their lungs. My friend's aunt, when we were teenagers, had terrible emphysema from smoking and COPD, to the point where she said she could barely cross the room without stopping to rest. And she was on oxygen, and we said to her, Auntie, tell us how that feels. And she said, I'll tell you exactly how it feels. She said, take the very deepest breath that you can, and then try to breathe on top of it. And that's what it feels like for me every single moment of every single day.
Wow.
And then she lit another cigarette. So this is something that you do run into. If she's cut back from 3 packs a day to a pack a day, that's still a step. And then what we know about the recovery process is that it is not linear, which we said, and it is not all in one direction, as we said, or this would be a picture of a highway. It's a roller coaster, and you can loop back and start where you started and have to go from the beginning and forward with your journey. So, Anne, would you like to do this next section?
Yeah, let's talk a little bit about, I think we're edging into practical methods for harm reduction. And so these are some of the things to think about when you're working with people who have the trauma and the shame that Sherry talked about, and the deadly illness of substance use disorder and the deadly condition of homelessness. The situation is dire, but there are things that you can do. One of the first things that I have always found helpful is the conceptualization of this cycle of change. And here's the upward spiral, okay? And almost everybody in our field has seen this, but I'll walk you through it just in case you haven't seen it. This is really kind of a way to conceptualize how people begin and move through the process of getting better. And so pre-contemplation is, you're going to find a lot of people in pre-contemplation, right? Sherry shook her finger at me a little while ago. And, and if I'm in pre-contemplation, my answer to that is, I don't have a problem, get out of my face, right? That's the kind of thing that, and people will say, I just drink a bit. I just one or two beers. That's kind of a joke in the recovery field. Yeah, 2 beers a minute. Anyway, the next is, as the consequences catch up to people, they begin to contemplate the possibility that they might have a problem, right? And so They may rock along in denial for a while, but reality keeps hitting them in the face. They're in the hospital again. They're arrested again. They fall asleep on the sidewalk and wake up in the rain, and so reality keeps hitting them and they're starting to think about it. Preparation, I think, is as much about entertaining the possibility of what would it look like if I wasn't doing this, or if I wasn't doing this quite so much. And then action is where people are taking some of the first steps around trying out new things, trying out new behaviors. And then maintenance is, action and maintenance are sort of talk about back and forth, but action, I've decided that I'm going to give up drugs and just drink beer. Okay. And then maintenance is I'm continuing to do that. And action, I might slip back to action and think, well, just a little marijuana wouldn't hurt, right? It's organic after all, right? And so there's a little bit of back and forth. And sometimes that back and forth leads to that last circle there, which is relapse. I don't want anybody to think that relapse is always part of the illness, because it's not. But for the people who can benefit most from harm reduction, they may have tried an abstinence-only program and just it didn't fit for them, and that's fine. And so for people in this cycle, this upward spiral towards recovery, relapse is often something that they experience. So there are do's and don'ts, okay? And I love this slide because it is a pretty good summary. For me, the bottom line comes down to, I can't tell anybody what to do. If that was going to be successful, we things would be different. But the problem is that we're all human, and sort of without this training and without this frame of reference, the temptation might be to say, to get into a power struggle, right? To say, Sherry, you told me you weren't going to drink, and here you are drinking. What is that about? Sherry's, leave me alone. Yeah, whatever. And that sort of head-to-head confrontation, that's not helping anybody. Sherry's already said that. It's not helping the person you're trying to help, nor is it helping you, right? It's not an effective, clinically based, evidence-based approach, which is what we're doing here. So what we do instead of confrontation, arguing, power struggling, and the righting reflex, we talk about, we approach people with a consistent positive regard, right? Even when you're coming up on somebody at a feeding ministry and they are wasted completely, and you're still happy to see them, you recognize them, speak to them by name, speak respectfully, check in with what they're doing. Can I come back some other time? Right? Not confront, but be with. Accept what people say. People who are using substances frequently lie. And so instead of getting into a power struggle over that, or demeaning them by letting them know that they're lying, right? This is not about you, right? This is about them. So we accept what they say because it's true for them. And in that moment, people who are using substance, one of the features of the disease is that people lie to themselves. So they're lying to you, but they might be lying to themselves first. Be mindful about who's in charge here. If I could control people, it'd be different, but I have no control. The person who you're trying to help is in charge of their own recovery. And, accept that experience allows for growth. And I'll stop here because I forgot to ask Sherry if she had something to contribute to either last slide or this slide.
I know you do this really well, and I think you've portrayed it well. I think one of the things I've learned from my friend Anne through this work is act as if. So it isn't, I think I told this story about the gentleman I knew, Coyote, who was sitting in the library sipping a little wine. That was hugely, evidence of harm reduction for him, because he had been a confirmed, he had struggled with alcoholism his whole adult life, and he was an older man. I'm just sipping a little wine. But act as if. I mean, the reality is he's made big strides. That is a big deal. And what you want to do is be able to keep him in the housing long enough that he has time to take a breath and begin sorting things out for himself. One of the gifts that you bring, one of the things that we bring to this field and why we're drawn to it, is we really have the ability to see people. We see people through the dirt, and we see people through the pain, and we see people through the, through the substance. You see somebody, right? I will say that a lot of people will cross the street or look away or not see. And I think that is really more common than we like to admit. But when somebody is seen, when you really see somebody and you say, Joe, I am tickled that you are doing better today than you were doing last week. Good job. That is a huge gift. When somebody is seeing themselves as a failure, or they've been treated as less than maybe their whole life. So this is act as if. So, thanks.
Yeah, I agree. I agree. And I think, on a practical level, the whole thing about meeting people where they are is understanding the context within which they are acting, right? So going back to the upward spiral for change, the fact that Coyote is sitting in the library drinking a bit of wine is a huge change for him, right? Now, this is probably not going to look good to the librarian, maybe, right? And so part of the balancing act that will be yours occasionally, but also your agency's, is to sort of manage the incorrect perceptions of harm reduction, right? So I'm not saying to Coyote, here, you have permission to drink, and here's another pint. No, that's not, that's not harm reduction. Might look like it to the librarian, but it is not. It is meeting him where he's at, recognizing and validating his progress, and walking side by side with him forward into his recovery. So one of the things that I've seen outreach workers do this over and over again, they'll come up on somebody and they were hoping that they were still in recovery, and they come up on somebody and they're in the middle of a horrible relapse. They're drunk or stoned or high on something, and they're a mess, the approach is, hey man, how you doing? Anything I can do for you today, right? It's cold out here. You want to try to come indoors? You want to try to come indoors? I can help you do that. Not saying, what were you thinking? That's more of a human reaction, an untrained human reaction. So here are some supportive questions for change that I hope illustrate what I was just trying to say. When somebody comes to you and they're in contemplation or preparation stages, remember that slide, you can say to them, if you were going to make a change, what would it be? And the answer might be, I'd like to sleep indoors more often, rather than I'd like to stop drinking, right? Okay, let's talk about how to sleep indoors more often. And then the next question is, if that didn't happen, if you don't change and sleep indoors more often, what might happen? What's at stake? And the answer is, I could freeze to death outdoors, right? And then if you were to make a change, how would you define that it was good, right? That it worked? What can I do can I help you, right? And what's your first step? Let's talk about what's the first step towards staying indoors. And the first step towards staying indoors might be that you get in line at the shelter when you're not so drunk you can't stand, right? That's the first step, able to get through the line. And we can just go from there. Sherry, would you add
Absolutely.
anything to that?
Yeah, actually, the one thing I just want to sort of go back and underline something we talked about at the beginning, which is the whole intent of harm reduction is to reduce the impact of the behavior, right? And with the state of the world today, the drugs these are not your grandfather's drugs. These drugs are not something you can experiment with and wander off and get back on with your life easily. Oftentimes they're highly addictive, extremely powerful drugs. What you are really doing by using these harm reduction strategies, and I will also say, alcohol is still the #1 killer, right? Fentanyl and the opioids, are several steps below that. Alcohol is the #1 killer. The reality is you are giving people the tools they need to stay alive long enough to find recovery.
Mm-hmm. Yep.
We are keeping people alive using these strategies. And I think that is, if you don't hear anything else from me, I think that is one of the most important things that you can remember about harm reduction.
Mm-hmm. Agreed. Yeah, we're giving people a chance to make a different decision tomorrow, right? If you've got somebody in total relapse, that's great. That is what it is. It is what it is. But helping them get indoors, helping them get the help they need for that moment gives them another shot at it tomorrow. Okay, so these are presented as questions that we think are good. They're the kinds of things. One of the things about harm reduction that I forgot to say is that you're going to have some conversations with people that might not be comfortable for you, right? Might not be comfortable for you. So talking to people about naloxone to prevent overdose, talking to them about using condoms, talking to people about are they worried about their drug use? Harm reduction is not permission to drink or use, and harm reduction is not I'm ignoring the problem and pretending it's not there. Harm reduction is in the middle between those two extremes, right? Those two, that on one end, and then a intrusive persistence around abstinence on the other. So you are operating in the squishy middle when you're doing harm reduction. So what you don't do is this with the finger, right? You're at risk of overdose. Aren't you scared? Is that going to help? No. What did we just learn from Sherry about trauma and shame? Right? And then you should get tested for STDs, right? Oh, and don't touch me, right? don't say that. If our job, your job, is to work with people where they're at and help bring them in incremental steps. People make incremental steps towards recovery. And we have to be patient and respectful while people do that.
And I would add, it's also human to say, you know, to my friend's aunt, really another cigarette? You really need another cigarette when it feels like you're breathing on top of a full, full breath? Or, really you need another cookie when you're already, 400 pounds and growing? Those are not helpful, and yet they're human, because especially if it's someone you care about, and I do believe that the folks we work with count in that population of folks that we care about. You want them to be okay. We are in these helping professions, we want to make a difference for people, and we want to bring them in and make them safe. And sometimes, you'll think, really? And that is the worst thing you can do. I would just, suggest being aware of that impulse, which comes from oftentimes a very good place.
Right. I have a niece who is dying of congestive heart failure in rural Oklahoma, secondary to decades of methamphetamine use. And I went to see her last year, and she showed up 2 hours late for dinner, as high as she could be, right? And Sherry's exactly right. I can do this with a stranger, but my first impulse was I wanted to hit her. Stop doing what you're doing. You're going to die. But I didn't do that. And I used what I've learned in terms of these harm reduction techniques to listen to her and what her concerns were. And 15 months later, she's still fine. She's going strong. And she's still using. So in a context for me, Sherry's right. When it's very personal, it gets a little harder, but the principles are the same. And why have we spent almost an hour talking to you about harm reduction? That's my question to introduce this last section. What does it matter? Well, it matters because your successful implementation of harm reduction approaches is going to increase the chances that the person you're serving will be able to stay in their housing. And that's for us what it's all about. Housing first, as we've seen in previous modules, is all about getting people into housing. In the same way, harm reduction is getting people one step closer to recovery, right? So it's all incremental steps. Housing first cannot operate without good harm reduction. So housing first, the principles that we've talked about housing first all the way through, it's person-centered, strengths-based, recovery-oriented, respect, respect, respect. Harm reduction is exactly the same. When you look at housing retention, what you become focused on is how can the person meet the requirements of their lease? How can they stay in the housing? So the kinds of things that come up is, people get drunk or high and they start knocking on their neighbors' doors at midnight. Okay. This is a lease violation, potentially. It threatens their housing. So the harm reduction approach in connection with housing first is, let's talk about how you can resist the temptation to knock on people's doors when you get high, right? Let's talk about how to do that. What could you do instead? What could you do instead? Now, of course, we don't want people to get high and risk their lives by using drugs, but the fact of the matter is we're also focused on helping them keep a place that they have, that they value, right? That exits them from homelessness. Another example of harm reduction and housing first is in conjunction. There was a story of a man who would sit on his doorstep, right, on the little front porch of the apartment complex, drinking a beer. And when people would approach him, he'd like, right, just grumpy and a little threatening, right? And the harm reduction in that is to work with him on finding a different place to drink his beer, or learning a couple of phrases when people approach him for him to say, yeah, how you doing? Instead of pushing people away. And so it's not about getting people to stop. It's about getting people to reduce the harm. And in the housing programs, the reduction of harm is not just about people's physical health. It's also about preserving the rights of tenancy. Sherry, what did I leave out of that?
I don't really think you left anything out. I think one of the important things to get away from, if you're going to really practice harm reduction, is this either or. You're either sober or you're not. And if you're not, you are, bad. And if you are, you're good. It's like, there's no either or. This is a continuum, and it's all about the forward progress. And if you slip back into either, it's okay. You're human. You're going to make mistakes. You're going to not be able to manage this perfectly every single time. Giving that grace to fail and retrieve your recovery is huge. I mean, it's just absolutely gives permission to start this slow incremental progress.
Yes, an incremental progress, but from the perspective of the housing lens, it's, we want you to be better and do better, and I'm here to help you. Show me, let's see where you are in the cycle of change, all of that. But while we're doing that, let's pay your rent. Right?
Let's make sure we don't disturb the peaceful enjoyment of the neighbors.
Right.
That's not
right.
Yeah.
And you cannot have a campfire in your living room. It's a focus on, it's almost like you're triaging the harm, and the harm first and foremost is to people's health and safety and well-being. But second, from a housing coordinator's perspective, it's about preserving the tenancy.
Absolutely. And it's very strength-based.
Yes.
And person-centered, and everybody's the expert on their own life. And I would like to just point out that a lot of Housing First programs in Missouri do have eligibility documentation requirements. That does not mean it isn't Housing First. I'm just think it's important to point that out.
Yes, I think that is, yeah, if in order to be eligible for the program, you have to be homeless, that's way different than saying you have to be sober.
Right.
Yeah, absolutely. All right, well, I think that brings us to the end of Module 4. In Module 5, we're going to talk about safety practices. We'll see you then.
Thanks, everyone.